Yeah, thank you very much for the kind introduction. I'm very happy to be here today. And I want to make an argument how we should build a clinical AI infrastructure to be able to bring AI from lab to the clinic. What we've seen in the past few years is that AI demos got quite impressive. We've seen that AI can be used for a lot of use cases in healthcare, but still, if you walk through a hospital today, the work itself often looks completely unchanged. We have the same records, the same clicks, the same manual search through years of documentation. So the question should no longer be, can AI do something useful? It certainly can. The question is, why does useful AI so rarely become part of our routine clinical healthcare? There are many answers. Regulation, liability, procurement, reimbursements, they all matter. But I want to focus today on one answer that is often underestimated, and that is infrastructure. To me, from lab to clinic does not mean building one more impressive demo. From lab to clinic means building the infrastructure that allows AI to run inside our hospitals. And I want to make the argument that this infrastructure should not live only in the cloud. Hospitals need local AI capacity too. Not instead of the cloud, but as their own base layer. At our radiology department at TUM University, we started building exactly this. We basically built our own local API inside the hospital. For our developers, that feels quite similar to calling a cloud model. So a request goes in, an answer comes back. But the model runs on our own GPUs behind our own firewall with our own monitoring. And one of the systems that we currently have running on top of this infrastructure is an agentic system for clinical records in patients with complex diseases. A patient record is not one clean document. It's actually a long history. In our dataset, records covers years of clinical care. They include documents, laboratory values, changing treatment decisions. For one patient, the relevant answer may be spread across old records, new lab results, and revised treatment decisions. So our system has to do more than search. A clinician asks a question about a patient, the system interprets the question, retrieves evidence from the record, uses tools where needed, and returns an answer with sources. So this is no longer a simple chatbot. It becomes actually an active multi-tool database workflow. And we are working on several clinical use cases, for example, finding a disease status with patients with lung carcinoma by interacting directly with our medical database. Once the AI becomes a workflow, the economics change. Somewhere in the project, almost as an experiment, we added simulated cloud costs to our local API server. We looked up what the model we currently serve would cost if we run the same workload, let's say on an AWS server, for example. And we were quite surprised with the results. Even at our current scale, the cloud equivalent cost would be between roughly 200 and 800 euros per day, depending on how heavily we use the system. And that was actually the moment I realized that on-premise hosting in a hospital setting is not simply trading cost for privacy. In contrast, it can be cheaper and more secure at the same time. Of course, the hardware is not cheap, especially in recent months, the costs have increased. We currently use one server with 2 high-performance GPUs, and that system costs us approximately 80,000 euros. And given the current usage we have on that, the server basically pays for itself in approximately a year. And after that, the economics change. We are no longer asking every day how many requests can we afford to send to an external model. We own the capacity. And that's actually quite an important difference, because the goal of clinical AI is not to use it rarely. The goal is to use it wherever it reliably reduces work. If every successful workflow creates a new variable bill, the hospitals will start rationing AI exactly when it becomes useful. And that is the wrong incentive. A hospital should not be afraid that adoption works too well. This is why I think AI costs is not just a finance topic, it's an adoption topic, it's a workflow topic, and in the end, it's a clinical infrastructure topic. Hospitals actually understand this topic in other areas. For example, in radiology, we buy scanners, we buy PACS, we buy servers, and we do this because some capabilities are actually too central to feel like a micro transaction every time we use them. If a capability becomes part of our routine clinical care, we need a cost structure that supports our routine use cases. And I think that clinical AI is moving in exactly that direction. So don't get me wrong, this does not mean that we should run every AI model locally. There are certainly some use cases where we need the newest frontier models and where we need cloud. For example, for very hard reasoning tasks, cloud models are still the right choice. I think that the best performance comes from size and scale, and we are hospitals, not data centers. And many hospitals, for many daily tasks, do actually not need the most powerful model in the world. They need models that are fast, stable, private, and simply good enough for the workflow. Using frontier intelligence for every routine hospital task is like driving a Ferrari to buy groceries. It certainly works, but it's not the right infrastructure strategy. For many clinical workflows, local models are already good enough. For structured work record summarization, extraction, source-grounded answers, and administrative support, they are good enough and can be used for many everyday tasks. Open models are usually behind the newest frontier system when we just look at the performance. But the gap has become small enough for many routine workflows, they are no longer the limiting factor. So the question is not if local models can beat the best model in the world. The question is our local model strategy good enough for defined tasks at defined costs with the privacy we need in hospital settings and with the level of control it allows? And for many hospitals, the answer is actually yes. What we also found is that local AI can keep up. In our local setup with only 2 GPUs, we currently process roughly the amount of text in the first Harry Potter book every 10 seconds. And this is not hyperscale, but it's also not a research toy. It proves an important point, and that is that an AI infrastructure in a hospital can work. It can serve serious volume, it can be monitored, it can be measured, and it can run behind a firewall. That matters because cost is only the first part of the argument. Local infrastructure also changes who controls the system. The hospital controls where the data goes, it controls which model is running, it controls the logs, it controls when we want to update, it controls the pricing exposure. And essentially, the hospital controls what is happening if external access, pricing, or any regulation changes. So it's institutional control over a new clinical capability. This matters especially for privacy. Hospitals hold one of the most sensitive data sources in the world. Medical data is intimate, longitudinal, and often impossible to truly anonymize. So the question should not be which model gives us the best results. The question should be, for this specific task, does the data need to leave the hospital? And sometimes the answer may be yes, but for some tasks, it's also good to use local models. Also, there are hidden costs for cloud AI that do not appear in the hospital bill. And that is legal review, data protection assessment, vendor negotiation, audit trails, and risk assessment. And still, that doesn't mean we should avoid the cloud entirely. It means we should stop treating it as the default mechanism, and we should use local AI in the hospital when it makes sense. Thus, when a frontier model is truly needed, we can still use it, but we should use it deliberately. And that is also crucial for stability. Cloud AI changes quickly, models are replaced, versions disappear, pricing changes, and access conditions can also change. That pace is quite normal and also wished for in the technology industry, but healthcare is quite different. If we evaluate a model for a clinical workflow, train people around it and monitor its behavior, we need the system to remain stable long enough to understand it. And in medicine, stability is actually not the opposite of innovation. Stability is a safety feature. So local infrastructure lets hospitals decide when to update, when to validate again, and when to keep a model unchanged. what I also have to talk about is the current operational talent bottleneck. We are currently in a phase of the so-called passion project vulnerability. So current hospital AI deployment entirely relies on passionate researchers working with sheer personal dedication. Standard clinical IT is currently not built to maintain complex agentic workflows. It's built for our standard hospital setting. So handing over advanced models without structural upskilling would lead to an immediate pipeline failure and performance drops. There were several systematic gaps identified in Germany, and what we're currently aiming for is to match research excellence with active technical training for operational clinical personnel to sustain our routine clinical care. So we do not only need infrastructure investments in our GPUs, we also need to focus on building our local engineering capability. The same is true for sovereignty. A hospital that owns no AI infrastructure becomes only a buyer. It cannot easily compare models, it cannot easily test alternatives, it cannot build institutional knowledge about what works and what fails. If regulation, pricing, or vendor access changes, the hospital's ability to maneuver shrinks significantly. So local infrastructure does not solve every dependency, but it prevents the total dependency. This is actually quite similar to what happened in radiology. Radiology did not become digital because someone built, let's say, one beautiful image viewer. It became digital because hospitals built PACS, networks, storage, standards, worklists, and governance. And clinical AI, I think, will be quite similar. The model is not the product, the infrastructure around the model is the product, and that infrastructure should not live only outside the hospital. So this is the architecture I think healthcare needs. We need local where it matters, cloud where it helps, and governance across both. So the goal is certainly not that every hospital trains frontier models. That would be unrealistic. The goal is that serious hospitals own enough AI capacity to run routine, sensitive, high-flow workflows themselves. And the cloud then becomes kind of an escalation layer, not the default destination for every request. So the question is not only which AI applications a hospital should buy. The deeper question is what AI capacity the hospital should own and who controls the model, the data flow, the logs, the costs, and the updates. If we do not answer this, clinical AI will remain stuck between impressive prototypes and fragile deployments. If we do answer it, hospitals can become active operators and not passive consumers. They can use cloud models where the benefit is clear, and they can use local models where privacy, cost, speed, and stability matter most. They can evaluate both, they can govern both, but my message today is simply that if we want clinical AI in real hospitals, we should stop treating AI as just another software subscription. We should treat it as a clinical infrastructure, and the future of clinical AI, I think, is not one more cloud demo. It's a hospital-owned AI infrastructure, local where it matters, cloud where it helps, and governed everywhere. Thank you very much for your attention.